Hey everyone, and thanks so much for joining us today for our rescheduled and final TMC seminar of the fall semester. I'm Warren Kinghorn. I'm co-director of the Theology, Medicine, and Culture Initiative. And it's my real pleasure to introduce Dr. Emily Smith, who's our seminar speaker for today. Dr. Smith is here at Duke as Assistant Professor in Emergency Medicine and Surgery, Assistant Research Professor of Global Health. She has interests including children's global surgery, poverty metrics, health economics, and global health policy. As an epidemiologist, she's worked with her in-country partners at the Edna Adan Hospital in Somaliland for the past 5 years on projects related to children's surgical care, including defining the epidemiologic burden, assessing poverty trajectories among families with a child's surgical need, geospatial analyses, and healthcare infrastructure. Prior to her work at Duke, she worked at UNC Chapel Hill, involved utilizing epidemiological methods, mathematical modeling techniques, and cost-effectiveness research to determine effectiveness of various testing strategies among HIV-exposed infants in sub-Saharan Africa. Dr. Smith has a bachelor's degree from Wayland Baptist University, Master of Science in Public Health from University of South Carolina, Columbia, a PhD from UNC Chapel Hill. And Dr. Smith, we're incredibly grateful for you to being here with us today. Welcome, Dr. Smith, to present on a topic titled The Science of the Good Samaritan.
Thank you. Thank you for having me. We're getting the slides pulled up, and I needed some help. So thanks, Piper. Thank you. I'm thrilled to be here. This talk is born out of a kind of a life work a little bit, but certainly out of the pandemic and everything that happened there. So you will see this mix of faith and science, and which a lot of people don't necessarily want to talk about all the time. So I'm Emily Smith. I am an assistant professor here doing global health work at the Duke Global Health Institute in the School of Medicine, and I'm just thrilled to be here. I also today I'm going to be talking a lot about equity type work, decolonialism, paternalistic societies, nationalism. I mean, all of those words. And I deeply need to acknowledge my own social location of who I am. I'm a global health epidemiologist, like I just talked about, who it's a real privilege to be able to graduate and also work in some high income settings and universities. But with that comes some privilege and some advantages and power. I also want to acknowledge the land that I live and work on here in North Carolina, and also the land that I grew up on in New Mexico. So I've worked very hard to decolonialize and recenter my heart and work, but it is a continual process. And so I think that needs to be set up front as a social location, who I am as a person. I also want to acknowledge I am a scientist, but I'm also a pastor's wife of nearly 20 years, Baptist pastor's wife, and grew up in the church, in the charismatic church, and now we go to a more liturgical. So maybe I'm confused at what to do, but all that to say, I love the church. And so my critiques are out of love from it, the Big C church, and you will likely hear that today. So the Good Samaritan story, we're going to go a little bit more in depth at what that is and the next couple slides. But, it's a story of someone hurting on the side of the road. Two people walked by and then one stopped and did something about it. Now, when I got into epidemiology, one of the first thoughts was this is the science of the Good Samaritan. It's quantifying a need through data and rigorous data collection processes, and then choosing not to walk by. So it's really personal, this faith and science interaction that flows pretty naturally, vice versa. I'm not sure which one comes first. Because of that, this is all disclaimer, I guess, for the rest of the talk. During the pandemic, I started a Facebook page because I was getting a lot of questions from my friends and real life neighbors of, should we worry about this? What does flatten the curve mean? And do we really need to buy 500 rolls of toilet paper? And that answer was always no. But I started it as friendly neighbor epidemiologist with maybe 10 or 20 people that I knew following it. Friendly because I I tend to be too friendly. I'm sorry if I sit by you on an airplane. And neighbor, because I knew something like COVID meant that what I do affects you and what you do affects me. It would create this sense of neighboring one another well. I also knew from doing health equity research for a while that the people that were on the margins of society, of vulnerability according to not only medical, but social needs and money and income would be affected the most. So I was so gung-ho at the beginning of this is the time for the Big C Church to show love thy neighbor in a very real way. Now, over a year and a half, that grew to about 110,000 followers and about a reach of 10 million, which is just weird to me because that dubs me an influencer. But I think what it showed me is that there is a large group of people, most were the US, but there's definitely international, who resonated deeply with this thread of taking care of our neighbors and loving our neighbor. So I wrote about the science, but I also wrote about the why, which was the love your neighbor part. That work was featured in places like Time and the Washington Post and NPR, which is just mind-boggling to me, but also an honor. So I want to focus on the people who caught resonance with this. I mean, there were certainly the naysayers, like the haters were there as well, still are, but there are a large group who resonated with the question of how do we live this out in both word and in deed? And that's what I want to spend the rest of this presentation actually focusing on, starting with the science. So I do global surgery work. This is my wonderful team, part of them in Somaliland, the Horn of Africa, Dr. Shukri and her assistant. And I got into global surgery because it's a fairly new field, so we're all a bit scrappy. But it's also one where 5 billion people don't have access to surgical care. Now, that's a huge number. We just tipped the mark on 8 billion people in the world. So that's probably an underestimate. That seems to some people that we're overinflating that number. It can't be true. But we're measuring access to surgical care according to can you get to it timely? Can you get to it safely and receive it safely? And does it not bankrupt you? When you define it that way, that's not aspirational, that's just equitable. 5 billion people at least certainly do not have that type of access, and 90% of that group is located in low and middle income countries. So already this thread of quantifying the need and hopefully choosing not to walk by, that's in the low and middle income countries. And another reason, many of you know who this is in the picture, our dear friend, Dr. Farmer. In 2008, him and his colleague, Dr. Jim Kim, which y'all know likely as well, he's a past president of the World Bank and Partners in Health leader. They wrote this almost an op-ed about going for surgery in global health. And they said, you know, we've done a pretty good job at looking at the big three. Infectious diseases, HIV, malaria, and TB. Now we need to go for surgery. And they made this case that if we invest in surgery, it has this trickle-down effect to the rest of the healthcare system. It also is a huge marker of morbidity and mortality for the poorest of the poor. So, you know, these are leaders in global health. And so when they say something, people listen. And listen, they did. Over the next 7 years, there was an explosion of at least interest in global surgery. And it culminated in the Lancet Commission of Global Surgery that defined that 5 billion number. But also, what do we do about it? Now, our team here took that a little bit further to just focus on kiddos. And that I'm a mom of two, so it was a bit of a natural inclination. But also 50% of the population in low and middle income countries are kids. And of those 85%, it's a huge percentage of them will have some sort of surgical condition by the age of 15. Now, that could be something that's highly fatal, like a brain congenital abnormality, or it could be someone fell and broke their bone and they don't get it set right. That impacts the child's ability to walk to school, to get water, to contribute with their family. And then you forward that onto the rest of their life, it impacts trickle up all the way through. So we know that kiddos are a huge precursor to also economic instability in countries. Now, on these slides, when you see the papers, if you really want to get nerdy and look at the science of it, I put the papers for you to go a little bit more in depth. So we asked the question, can we go to one country and estimate in a really good, robust epidemiologic way how many kids in a country need surgical care, where are they, with the long-term goal of actually implementing interventions to get them to care and lessen that gap. So we went to Somaliland. Somaliland is an independent state in the Horn of Africa. The north of it is Yemen and south is Ethiopia. Now, technically, from the UN and WHO, it is a part of Somalia. So when money is given to countries, a lot of it doesn't actually funnel up to Somaliland. At the same time, it's a democratic country with some of my favorite colleagues. It is the fourth poorest country in the world, with some of the highest mortality rates for children and for mothers, like what you see on the slide. If you look over on those bar graphs, you have children under 5, then you have babies, and then you have mothers for mortality rates. That very bottom bar, that almost olive green, is the mortality rate for Somaliland. If you go one more up, that's neighboring Ethiopia. One more up is sub-Saharan Africa, and then one more up is the world. So it really is a place in some pretty dire need for a lot of things. So we asked the question again, how can you, in a country of 2 million kiddos, can we go to a random sample of them that would represent those 2 million and estimate how many of them need surgery? So we went to 1,000 homes all throughout the country, including some of the most really remote parts. And we asked typically they were the mothers, the caregivers there, are there any kids in the home who need surgery? Did they get surgery when they needed it? What part of the body? Did they unfortunately die from it or were impacted, in some way? Did you have to sell assets or land or camels in order to get them care if you did seek it? And not only that, then we went to the hospitals in the country. There's 15 hospitals that have an operating room in the country. And we looked at their log books, which is typically like a moleskin notebook, over the 1-year time period and recorded how many kids actually got surgery. Now, it's not a one-to-one match, but it does give you a story to tell. Of the kids who were at the homes in the 1,000 households, 250,000 of them needed surgery and only 1,200 actually got it. So that disparity, we could stop there and say that's quantifying the need, but that would be a little bit of walking by because we have that, but we need to go deeper. We know that 75% of the kids who made it to the hospital made it there, but they delayed in even getting there. So the question is why? And we measured that and we found 2 big precursors, again, of quantifying that need on a really granular scale for strategic implementation. The first one was geography. This is some geospatial analysis for you good engineer, nerdy people like me that like this stuff. This is the country of Somaliland, and the H's are the 15 hospitals that we went to. Almost the yellow and that peach that you see growing out of it, that's the proportion of kiddos who are within 2 hours of that hospital, which is our goal. Everybody else is outside of that time. And if you think of some of the most remote parts like Sanag and Aldal, the travel is on camel. And so it takes a long time to get to these hospitals. And that impacts something that's very life-threatening or acute for a child who needs care very quickly. And the second, which is probably the most significant to me, is poverty. It makes sense. But part of the science of the Good Samaritan for me is actually getting the anecdotal evidence out of our head and putting it into data. And people tend to listen a little bit more to that than anecdotes. What you're seeing on the slide here is what's called a poverty trajectory. And it's the same story we see here in the States as well. Somebody is not under poverty, but one ER visit or a child who needs care and you don't have very good insurance, it sinks that family into poverty. Now, some of those families can get out of poverty because they have a nest egg or they have friends or family that can loan them money. They can sell something. And in Somaliland, a lot of families would sell their camels or their goats. But then there are some families that get stuck. You see in that little dip, that's called a poverty trap. So what we wanted to ask is what differentiates the families that get stuck versus those that can actually climb out of it. And here's what we found. In Somaliland, out of all the nearly 1,000 homes that we went to, 12.5% of families went into poverty and never came out. They got stuck. 61% stayed the same and 26% went up. Then we disentangled our data and we separated the families into either having a kid with a surgical need or not having a kid with a surgical need. And here's where the story is. For the families that did not have a kid with a surgical need, about 11% got stuck in poverty and moved down. But for the families that did have a child with a surgical need, almost double the amount moved down into poverty and got stuck. This is even accounting for income of the family, number of other kids that they had to feed, remoteness, or how, if they were in an urban or rural area, the one predictor that came out was having a kid with a surgical need. It was really powerfully denoting the impact of just needing surgery for a kid. And one of the highlights of my professional career to date is taking this, along with some other incredible research with our colleagues, to the United Nations high-level meeting on universal health care. Now, who you see seated here are people like us. There's also ambassadors and grassroots efforts for LGBTQ protections in very remote type areas. And we were all there advocating for something. When you talk about universal health coverage, you have to include something. For us, we said surgery, that it would protect not only families from poverty, but we have good data that it would actually help bolster the economy and protect economies from poverty as well. The other pictures are my favorite collabor friend who is here at Duke, Dr. Henry Rice, and then me fangirling out to the president of the WHO. I'm probably saying something like, I love your work, but that's the picture we got. So now that is the science part. That's the science of quantifying a need and hopefully choosing not to walk by that we're building off of. I come from a Christian faith perspective, but when I talked about this during the pandemic, this notion of the Good Samaritan, it translated through pretty much all major religions, and also just being a good person. That quote at the very bottom is my kid, of just love your neighbor. That's just being a good human. That's what he said at the very beginning of the pandemic, and I tend to agree. So it transcends being a good person, and it transcends faith. So let's go there a little bit more, certainly through my lens as a Christian, but with this in mind. The story of the Good Samaritan is a story where two people walk by this man on the side of the road who was in need. One was a Levi and one was a priest. And at the time, both of them symbolized positions of power and of privilege. But a Samaritan walks by who is kind of an outcast at the time. He stops, and not only does he stop and take care of his acute needs, he puts him in lodging. He takes care of all of those expenses for lodging and for healthcare. It's an incredible story of holistic health of what that means. Now, this story was told because someone came up to Jesus and asked, "Who is my neighbor?" Now, we don't know the voice inflection of that person. Did he ask it of who is my neighbor? Just a question. Or did he ask it like a gotcha? Who is my neighbor? Regardless, Jesus didn't answer him with an answer. He answered him with the story. And at the end of the story, Jesus then asked a question that looks really similar. He asked the man who was the neighbor. So do you see the differences in posturing? One, who is my neighbor, is almost, how much do I need to tithe? How much do I need to give? How much do I need to do to almost do almost like a checkbox? What is just enough to stay comfortable? The other was a state of being. The who was the neighbor is a worldview. It's a centering. It's an automatic stopping because somebody is in need. Those posturings and those centerings, those actions are very different when you actually look at the internal heart, I think, of the person. And this isn't the first time that we see Jesus redefining that. In many of his other teachings, he gets a child. And he puts the child in the middle of the group. He stops, one of my favorite stories is he stops entire groups of people and he asked, who touched me? And the person who was there was the woman who had spent all of her money, an impoverished woman, for healthcare, and said it was me. He centers on the lepers and on touching and kind of the uncenterable at the time. So I think that he's got a story to tell us through all of this. And I want to end the lecture with going of how do we do that then? Not only with us individually, but our collective lives, like a good epidemiologist, collective societies and economies as well, starting with how do we live? And the first is this word of solidarity. You know, the first time I heard this word that I remember is Dr. Paul Farmer. When I was getting my master's, I heard he was coming to the university that I was at. And so I snuck in somehow and I brought all 5 of his huge books because he's an anthropologist, so they're a bit wordy. No shade, I've read them all, they're wonderful. And he signed them all. And to all of them, he said, in solidarity, Paul. 10 years later, you know, we had known each other a little bit because of global surgery. And he came into a lecture we were both at. And he gave me a hug. And then he handed me his new book. And I opened it up and it says, in solidarity. And so I told him this fun story. And we both had this neat moment. But I told Paul, I said, I think solidarity is what anchors you. And it got in me of hopefully what has anchored me as well. Solidarity is not seeing people as projects. It's not seeing communities as projects. It's almost like a power play. It is a witness, W-I-T-H, witness, and a witness, I guess. It is a coming alongside people. It's accompanying them for you liberation theology people. I think this quote by Desmond Tutu sums that up really well. I don't preach a social gospel. I preach the gospel, period. When people were hungry, Jesus didn't say, now is that political or social? He said, I feed you because the good news to a hungry person is bread. So that posturing of solidarity is really important when we do this work. The posturing of solidarity as countries is important as well. So when we start talking about collective solidarity, we have to take into account history. I call these collective walking bys, again, with the Good Samaritan story, seeing a problem and not doing anything about it or covering it up somehow. And the American church, the Big C church, doesn't quite like to do this a lot of times. As an example, there was a false belief that Black bodies are hardier than white bodies, and that was used to justify slavery right alongside with some really terrible readings of scripture. That same belief trickled down to medical textbooks. In 1863, the introduction of anthropology wrote, the skeleton of the Negro is heavier, the bones are thicker. And so radiologists and technicians were taught to expose higher proportions of radiation. That belief persisted even nearly 100 years later. In 1959, an atlas of normal radiographic anatomy described the bones of Black people, specifically their skull bones, as thicker and denser than those of white people. That was not taken out of medical literature until 1997 in some places, and it wasn't actually debunked until 1968 by the United States Public Health Service National Center for Radiological Health. We see this same sort of structural racism that is passed down in pulse oximetry. Now, a lot of us had those little pulse ox machines that you put on your fingertips during the COVID pandemic. Those would give readings that were inaccurate for our African-American neighbors. Thereby, those false readings affected whether or not they received treatment, intubation, ventilator support, or even hospitalization. So it even has a trickle effect of mattering now. Now, this collective walking bias is just another way of talking about bias that's embedded within societies. And when that gets embedded in textbooks, in medical procedures, in families, and in workplaces, and then in courses, and in training, and in worldviews, and then in practice, and then in othering people, that inequity becomes structural. And then that inequity, that structural inequity, can become violent. Now, structural violence is another thing that the American church doesn't want to talk about, but it's violence that affects one, it causes harm. And typically we think of that as only individual. There's a lot of definitions for it, but this is one of my favorites. The bolded part in the quote, it's when the potential is higher than the actual, and by definition, that is avoidable. It means that if some people in the world are dying of something or being affected by something or harm inflicted by something that others in another part of the world are not, is that violence? Is that structural violence? I would say yes. And Muhammad Gandhi's a quote about poverty being the worst form of violence, I agree with that. So these are collective solidarities of walking by that historically we have to take account of to hopefully make some changes and for it to not to continue. Now, part of that reframing our mind is getting into the reality. I titled this slide "When the Minority is Actually the Majority and We Miss It." And by we, I mean either the American church or people in high income countries. And let me give you an example of this. Do you own a car? 90% of other Americans do. 80% of Germany, New Zealand, Britain do too. So it's no wonder that we think everybody owns a car. But when you zoom out to the rest of the world, only 18% own a car. What about food in your pantry? There's a whopping 32% of families in the US that are under the poverty line that cannot meet their basic food need. That's almost double than those that are above that poverty line. And that was before the pandemic. After the pandemic, that widened, and it's not equal. Food insecurity is 2.5 times higher for Black families and 2 times higher for Hispanic families than for white households. So what we think is the majority might be the minority or vice versa. What about stable internet, access to a library, electricity and safe water? And I'm talking about aspirational, equitable, reliably and daily kind, health insurance, even just a little bit. 85% of the world lives on less than $30 a day. So the majority of the world that doesn't have health insurance or clean water or a nest egg for a rainy day or stable food and housing, but the world's power and privilege is typically centered around just a minority few. So how do we recenter, reorient according to who Jesus, I think, would consider the majority? I think it's who he's centered on in the story, in his parables and work. And I'd be remiss if we didn't talk about another majority. This is the picture of the prayer rally, the national prayer rally that happened September 2020. At the time, the world had just passed 1 million deaths globally, and the US was averaging 44,000 COVID cases per day. We were weeks from going into the worst winter of the pandemic that many of us don't want to revisit. What I want to show here is there was not a lot of masking. There was a lot of talk about faith over fear, some really warping views of scripture and COVID that if you're watching this webinar, I don't need to tell you all of that because you lived it just along beside me. But we have this misconception that this is just a vocal minority. We have good data showing that is actually not the case, that it is a growing majority, at least in the evangelical church, particularly for nationalistic type views instead of collective solidarity for globalism. So I think we need to take that into account. It might not look like this is the truth, that it is a majority, but if you lived where I was in Texas, it's not hard to believe. Some of the worst, I received a lot of threats and a lot of harassment. None of them came from non-Christians, and some of the worst kinds, including those at my home and against my children, were people that lived within a 2-mile radius from me or I went to church with. So this is live and growing, and to recenter and reorient means we speak against this when it's appropriate. Now, a way to see how we can do that with our heart, or perhaps push back on some people, is look between these 2 verses. Which one do you identify the most? Those that are longing for the good old days without recognizing that those were only a good old days for a select few and not for all, are saying, peace, peace, let's have faith over fear, take your mask off. That is peace, peace when there is no peace. On the other hand, if you went through the pandemic and you more likely resonated with the Amos passage of let justice roll down as waters and righteousness as a mighty stream, like a waterfall. Justice needs to happen. There's actually no peace. I think we get it right. We get what Jesus would have felt, and likely what he did feel there during the pandemic and still does. So when his majority becomes my majority, everything changes. My effort, my talents, my money, my worldviews, my politics and voting, also my redefinition of freedom. The last slides we're talking about framing, but now we've got to talk about how do I define my freedom? And this is a Message Bible translation where it says, sure, yes, God has called us to be free, but not for whatever we want to do. It's to serve one another in love, that the whole scriptures could be summed up in that one sentence: love others like yourself. That's an act of true freedom. I think when we get that in our bones, then we become a people's, not just one person that is different. So I want to end with talking, I've done a lot of like mind shift worldview. How do we change as a society? But what about us? How do we change? And one is to talk about more than just money, or throwing money at problems or countries will not solve it. Many of you know Father Gutierrez in Liberation Theology, incredible writer and just a person who has lived this out. But he said the poverty of the poor is not a call to generous relief action or just money, but a demand that we go and build a social order. Now, this came out in our data, and I want to show you an example of how that matters. We asked the question in Somaliland. We knew that families would get stuck in that poverty gap that I talked a couple of slides ago. So what if we offset those expenses? What if we reduced what they had to pay out of pocket? Could that protect those families? And would that be different depending on where they lived and how much money they made? And let me show you what we found. Now, to orient you to a lot of data that is coming out, this is on the x-axis is the risk of the population of catastrophic expenditure, your risk of going into poverty and being stuck there. Now, the part that I have in the red bar, that top bar is just baseline. It's families that had to pay out of pocket, and you can see nearly 100% of families are at risk of being stuck in that poverty gap if they have a kid with surgical need. That gray bar was, well, what if we offset that, but we pay 50% of their healthcare needs? It barely budged. It went to about 92%. What if we pay 70% of their healthcare needs? It's that darker blue bar. It only budged to about 75%. Now, this is the norm in Somaliland. What happens if we look at the poorest of the poor and the richest of the country? And here's what we found. The top 3 bars are the poorest of the poor. The take-home message here is even when we take off the table most of their healthcare needs, there's still a huge amount of catastrophic expenditure of getting stuck in poverty, probably because they had to pay for transportation to get there, or even lodging, or what about food? Look at the rich, though, at the very bottom. If we reduce costs, they certainly benefit. So this is a strong marker, at least for us, that we've got to do more than money for individuals. That is part of it. But what about bolstering the whole healthcare system? What about other countries giving a little bit more money, or a lot more money than they actually are, to help protect communities as a whole from going into catastrophic expenditure? Part of that means we have to redefine health and value. Now, what you're seeing here is a figure of the person. That's the percent of the world's population, and then it's how much they hold in terms of wealth. Go all the way to the right-hand side. Less than 1% of the population in the world owns 41% of the world's wealth. Now, you could easily put, instead of, we're talking about money here, you could put the distribution of doctors. You could put 1% of the world's population contributes a huge amount of fossil fuel, or climate change predictors. There's a lot that you can put here. I just am showing you income, but the case I'm trying to make is that the world's wealth, the world's not only income, but also distribution of resources and of health and of money is inequitable. And I am a firm believer that it's not that we need more money made in the world. It just needs to be distributed a little bit more, a lot more equitably. So we have to take that into account and redefine who gets what and how do we actually value life. And also to redefine what we call innovative. And I'm saying we as high income countries again. Now, this picture, many of you you probably know what this is. This was India during the second surge of COVID. These are rows and rows and rows of makeshift burning funeral pyres taken from a drone camera. This is from the New York Times article. And this was during those 4 months where COVID hit really hard. And at the height of it, especially in India, where it's the most populous country pretty much in the world, with a high rates of poverty and low hospital bed as well. So we saw an explosion, like a roller coaster of cases. In 4 weeks, COVID cases went from 400 to 13,000, and that's only in Delhi. When you look at the country as a whole, it peaked at 400,000 cases in a single day, and it remained essentially that high for about 3 weeks post. Within an 11-day period, India saw over 3.5 million cases. That's 1 in 10 people were infected in that time. So it's just an unimaginable magnitude. And what I want to talk about here is you hear about stories of oxygen running out in hospitals. Now, there were some makeshift ways where families were bringing in oxygen that they bought, if they could find it, or where you could almost siphon off oxygen from machines that weren't meant to perform that way. It was a stopgap. If we are not careful, we could call that, well, that's innovative. That's a way to get by with what people have. But is it innovative if it's unequal? Because I think the question behind that question is, why was there not enough oxygen there to begin with? Especially when the alarm bells started ringing, why not? There were places here in the US that nearly ran out, but certainly didn't. That takes us back to history, and that takes us back to collective solidarity as well. Is it innovative or is it unequal? If you read the rest of this article, it goes to one specific hospital in Delhi, where the alarms were going off. There were 24 COVID patients that needed oxygen, and they ran out of oxygen. And by the next morning, 26 patients had died. So that's not innovation, that's an equity. And if we call that what it is, then we get into the reality, I think, of the Good Samaritan. Now, after all that, that's the heavy stuff. I just want to end with maybe some encouragement or some wisdom. One is going back to the story of Nehemiah. It's one of my favorite books in the Bible. But we get this man who was a cupbearer for the king, it tells us at the end of chapter 1. And then he hears about destruction of a place that he loved. And so he gathered people up, he garnered, and they rebuilt the city. And as they were rebuilding, there are these kind of naysayers. It's almost like trolls of the time, like social media trolls. Sanballat was one of them, went and told one of the people to go tell Nehemiah, I want to take him to lunch. This is me paraphrasing. I'm not a biblical scholar. I tell him to come down. I want to talk. I think he's making some errors here. And when the person went and told Nehemiah, I think this holds the key for us to not get overwhelmed and for wisdom. Nehemiah didn't come and meet with him and argue and debate, which there is a time and a place for that for sure. He just said, I'm doing a good work and I'm not coming down. And he kept building, and over they went back with different, versions of that same story. And Nehemiah kept saying no. And I think if we're careful, we can get overwhelmed with the need, not only of health, but you can throw in climate change or gun violence or something, food insecurity, where inequities are very high. And we think, I've got to do it all or I can't do anything. I think the wisdom is for us to know personally what is the good work for me and not to come down from that. With the naysayers that are going to come, even the sneaky ones and invite you to lunch, if it's not in what you're building, there's wisdom in saying, no, I'm not going to come down and get distracted by that, nor am I going to get overwhelmed with other things that I can't control. So I just want to leave with that. I think it's another important fact to say it's okay to leave. Not every fight that is out there we have to take part in. We don't even, if we're invited, we don't even have to go, or we can just leave churches, leave communities. It's okay to leave, that there are other people who have solidarity, even if we can't see them right now. And I'm going to end with this. This is my hope for the future. I guess for mine and hopefully for my kiddos is a new table. You know, I used to say that there's one table and there's only so many seats and I need to give mine up to let somebody sit here. And I was reminded a couple of years ago that that's a scarcity mentality. I need to just, I tell my students, leave those tables, that in the new table that I think neighboring brings us to, there's enough seats for everybody. And in fact, it keeps growing. I think that neighboring interrupts us and asks us to come to that table, just like Jesus does at a new table. I think it's a table, like in scripture, in the middle of a wilderness or the presence of enemies. I think it's where bread and wine are broken in remembrance of body and blood. I think it's a table that looks like heaven, where the lowest person is at the head and the marginalized have been brought to the center, where there's enough to eat and to share and satisfied with extra baskets to take home. It's not monolithic and unicolor. I think it's a table of color and equality. And this is summed up in this is one of my favorite poems. Many of you probably know it. I'm just going to read the bolded part. It's that table will be wide, and the welcome will be wide, and the arms will open wide to gather us in, and our hearts will open wide to receive. And we will come as children who trust that there is enough. We will open our hands to the feast without shame, and we will turn toward each other without fear. And we will become bread for a hungering world, and we will become drink to those who thirst. And the blessed will become the blessing, and everywhere will be the feast. So that and everywhere will be the feast. It's a table of neighbors and neighboring. And I hope when we hear the question of who was the neighbor, that we can say it was us. It's been a privilege to be here, and I'm happy to take questions now. Let me stop sharing.
Thank you so much, Dr. Smith. Thanks for being with us. We do have a few questions in the chat that I will ask in order. But first, I just wanted to say, first of all, thank you for your talk. You brought a lot to us, and I wanted to ask you maybe just a bit about your personal story. You told us that you're a Christian. You told us that you're married to a pastor. You have a lot of experience in the church. How did you first come to care deeply about the things that you have been talking about today in this talk? Like, what were your first experiences that led you to care about this?
Yeah, that's such a great question. You know, my parents were really active in the church growing up, so I've always just been involved. And we were the home that the missionaries would stay in. Mm-hmm. So I just remember being really young, 7, 8, 9, and just pestering those poor people with 1,000 questions. And usually they just answered all of it. So something just stuck globally there. And I knew I always wanted to do global health. So that never really left. And then when I got married, Mike just feels very much the same way. So it was just natural to keep that going. But I don't know, I guess that thread started when I was little.
Yeah, thank you.
Yeah.
Thanks.
Yeah.
Our next question is specifically about interpretation of pandemic restrictions. This attendee says, what would you say to those who agree with you that we must do justice and prioritize the poor, maintain solidarity with our neighbors, but who have come to the conclusion that the lockdown measures and mandates in the pandemic were not well supported by data and caused disproportionate harms like to education and jobs lost and loneliness and depression and substance use and churches closed and so on? This attendee wants to know if that categorization of right and wrong is a little too simple.
Yeah. Oh, man, that's such a great question. And one that we've wrestled with for going on nearly 3 years at this point. I think I want to start that maybe with the taking a step back and knowing that it didn't have to be that way. It didn't have to be that bad. The 2 week lockdown that we all did at the beginning, or even if it extended to 4 weeks, had we done the tried and true rule book of epidemiology, infectious disease control, which it's not rocket science, we had that, we would look very different. Millions and millions of lives would have been saved at that point. And that's just not what some power countries, including the US, did. So that it could have looked different. With that said, once it got to a certain point that it was so bad, it just kept extending the lockdowns even further. And I do wish that we could have known. Well, we did know, but that it would have been followed. You can walk and chew gum at the same time, that we could keep essential businesses and mostly the businesses protected, while at the same time protecting families. There are ways to do that. There were ways, and we just didn't do it. So it's a big question that I can't answer in like 5 minutes, but that's what I would say. And also, I would challenge a little bit that we did have data of why those fairly rigid lockdowns at the beginning were necessary to come out of that correctly and to do what we needed to do within those 2 weeks or 4 week time period was not done that needed to be done. So that caused a lot of harm once things did open up.
Thank you. Thanks. To change the subject a little bit, our next attendee says, I'm curious to hear Dr. Smith talk about short-term surgical mission trips. Did they find a place within her framework of global surgical need and Good Samaritanism? Are there ways to be more thoughtful in our Western approach to enter impoverished and or marginalized locations with our surgical skills, talents, and technologies?
That's such a great question as well. I love the Good Samaritanism. I might take that. I might steal that a little bit. These are hard to talk about because I don't want to come across as there's no need for short-term medical missions. For decades, really good organizations have been doing work in some of the most remote parts that just people won't go to. And they're Christian. And they've been, I think, at Tenwick Hospital or Kajabi in Africa, and they've been there for a long time. So there's a need, just like in pandemic response, there's a need for acute help. And then it's what do you do after the fact? What is sustainable? And I do think that there's a way to have a conversation where you can come and be acute help with those organizations. But then, for example, some like the Mercy Ships are training in-country partners so that when they leave, they will have the sustainability to continue on with the work, even when they're gone. So I think it's both and I know that there's a lot of debate between that, but I have great friends who do medical missions work, and I agree with that. I think it's what happens after. And also the posturing, it seems like there's more and more people who will change and not go in with a white savior posture, but will go in as a solidarity or a witness. So I think it's changing.
Yeah. Have you seen examples of how that's been done well, where people have done that both and well, like in terms of collaboration or really connecting to work that's on the ground? Anything that you'd recommend specifically for those that are thinking about doing short-term trips?
Yeah, there's certainly organizations who do it better than the others. And the one that comes to mind is, again, the Mercy Ship for me. I spent a month on their boat, not doing anything medical because I was 19 and I worked in the kitchen, but they do a really good job at coming. And when they're there doing surgeries on the boat, on the whole ground floor of it, they train in-country partners that are right there. And they work with the country. There's a lot of conversations that happen before they even docked in those countries to do the work. So I love the Mercy Ships. I think they've done a great job at that.
Yeah, thank you. The next question is, were you able to do any analysis of reducing out-of-pocket costs impact on gross national product or other more national metrics?
I love that question as a good data nerd. The answer is no, but we're working on it. We want to do that. And I think that gets to, the slide where I say we need to do more than money. That was just looking at healthcare costs. But at what impacts a lot of families in terms of poverty is just paying for transportation to get there. In fact, the money that families will pay just to eat or to lodge or for transportation will actually bankrupt them more than healthcare costs. So we haven't yet, but it is needed.
Great, thank you.
Mm.
Next question. You spoke beautifully about solidarity as central to a meaningful response to poverty and injustice. Do you think true solidarity necessitates physical proximity to the suffering, especially those who are impoverished, or are there ways to be in solidarity at a distance?
I love that question. That's a great question as well. I think it's both and also I think it depends on what you are called to do. There are certainly people who will live in the poorest of the poor. You think of Father Gutierrez, like he lives there longer than for much longer than he is at Notre Dame. He lives in the slums, and there is need for that. But I also think there are some people who won't be called to do that for one reason or the other, and I think that's okay. I do think though that it takes more effort to check your heart in recentering and make sure that your solidarity isn't even subconsciously white savior-ish when you don't have that proximity. That means going or being friends. My Somaliland team, I mean, I'm not living there, but I talk with them a lot. We share pictures of babies and children, our own. And I think that friendship can develop that even without the proximity. But proximity matters in your heart. It certainly matters in location too.
Yeah, thank you. Our last question. We live in a time of incredible political, social polarization where it's hard for people to talk to one another around topics of significant political or religious difference. And that's certainly come out during the pandemic. I wonder if you could share wisdom or insight that you've learned through your work on Facebook as in the Friendly Neighborhood Epidemiologist, and things that you've learned the hard way, lessons that you've learned about what does it mean to be able to encourage people to communicate with each other? What does it mean to communicate well across positions of significant difference? How do we respond to the time of polarization that we find ourselves in now?
Mm-hmm.
And that both within the broader culture, but also specifically within the church.
No, gosh, I don't think I have an answer for this, but I mean, I can share lessons I'm continuing to learn. I am a natural peacemaker. And so at the beginning of the pandemic, I tried to interact with everybody, including, I mean, I think I just thought that if you talked logically to people and told them, especially the Christians, good Samaritan type of love, that it will change their minds. And that did not work for a good swath. That continues to not work. So I think the first thing I learned was like the Nehemiah verse of pick your battles, and just the wisdom to know that question was actually not a question that person asked me, and I'm not going to answer it, right? It's when somebody comes with a non-question question. And just to know to leave, to protect yourself, and that includes churches. I think it is very hard to decipher who like at the time I was in Texas at a pretty big evangelical church, who there would listen to this with an open heart and who wouldn't. Still surprises me who listens or who doesn't. And so some of it is taking a step of maybe courage and saying some things that need to be said, and then having the wisdom very quickly to know how the ending is going to be and leaving, either leaving or sticking with it. I don't know. I think protecting your mental health is important, that with all fights, you can't live in fight or flight at all times. So to find people around you who can encourage and bolster is really important as well. And then lastly, I would say for the church, I don't think we should keep holding on to what is not working. And that's where I keep saying it is okay to leave. There's a lot of talk of how do we get back the American church from the 50s. And that did not work for a good majority of the US, but a lot of, at least from the evangelical church, you don't see that until you see it. So I don't think it needs to be resurrected. I think a new one needs to emerge, and that might take some courage to just leave and leave some conversations. So it's a lot of wisdom. That was a non-answer answer. How about that?
Yeah, thank you. Well, it's a topic to which their answers are hard to come by. So I really appreciate that. Thank you.
Yeah.
Thanks so much for this talk. Thanks for being with us today. Really appreciate what you had to bring to us. So thank you very much.
Thank you for having me.